Yes, thank you, Mr. Chairman. Good morning, people. So I'm going to be talking about one of those special types of approaches that you need for all the varieties of fractures that we tend to face in a 25 million capital, which is where I come from, Cairo. And in fact, there are many ways you can deal with these injuries. Now, historically, there have been so many approaches that have been devised by Le Tournelle, among which the extended approaches took a good portion. But the recent German study group have shown us that a lot of the extensile and extended approaches have waned away from practice, and nowadays most of us tend to use more combined approaches for the complex and neglected cases. The extended iliofemoral approach, one of the most common and popular extensile approaches, was devised in the 70s by Le Tournelle. He used to do that in the lateral position, and the access was quite extensive. It gives you a good access to the outer aspect and the inner aspect of the ilium. And this is one case from the original book of Le Tournelle. He used to use these even for some acute cases, the complex associated both column fractures, the high transtectal, transverse, and T fractures. So this is one of Le Tournelle's cases, and you can identify the Vitalium type of screws and plates he used to use to obtain an anatomical reduction for these specific injuries. But the problem with this extensile approach is that it requires extensive elevation of the abductor mass, division of the lateral rotators of the hip, and you end up with a devascularized piece of bone on the ilium side, and basically the abductor mass is pedicled along the superior gluteal artery. And if you damage that while you're doing the approach, if you had an initial traumatic superior gluteal artery injury, you can end up with a dead mass of muscle. This has been also modified by some workers trying to divide the tendons by doing an osteotomy. It helped in the repair at the end of the procedures. But in our most practice now, I think that the posterior coccolangamic approach is a very versatile approach. It can be extensile by doing trochanteric osteotomies or flips and gives you much bigger access. You can even do that with a surgical dislocation and gives you a good access intra-articularly as well. We tend to use the lateral position if we want to extend the posterior approach. It gives you a better access to the anterior column. And by doing an osteotomy, you can fairly reach the anterior column as well, especially with a surgical dislocation. Few tricks you have to do is how to apply a lateral thrust in the lateral position to relieve the tension of the femoral head from your displaced fracture. So this is an associated both column fracture, which you can probably, by the Le Tournelle advice, use an extensile approach for such a complex injury to reach the anterior and the posterior column, but with well carried out strictly posterior approach, coccolangamic approach, you can actually use an extensile surgery and get an anatomical reduction and good fixation. Even a high transtectal fracture can be reduced with a single non-extensile surgical approach, and you can have an anatomical reduction on these fractures as well. Sometimes you want to extend your approach. You want to reach the anterior column more extensively than the classic ones. And for that, you can either do a trochanteric osteotomy. Nowadays, I tend to use a flip because the flip is less traumatic. It remains the synthetium of the abductors. And at the same time, you can get a good access intra-articularly to obtain a decent reduction as well. The classic triradiate by Dan Amies also have waned away, but it's the logical progression of the coccolangamic approach. So you have a coccolangamic approach, you extend it by a trochanteric flip or an osteotomy, and in very, very, very rare cases, you might need to convert that into a triradiate approach. But what about combined approaches? I think the workhorse for the neglected cases and the more complex cases in my hand are the combined approaches. Whether you use them in a floppy lateral position or a simultaneous position, but you can use the combined approaches for various areas. This is the access you get. You get the same access we heard from Professor Giannoudis from the anterior approaches, and you can have added to that the posterior approaches with or without a flip osteotomy. And in fact, this is a high transverse fracture. You need to reduce this in a floppy lateral position if you want, because also you have an associated posterior wall fracture, so an ilioinguinal approach will give you a fairly good access. You can easily recognize the widening of the SI joint, which is a classic pathological anatomy that we find when you have a central dislocation of a transverse fracture. It opens up the ilium away from the sacrum. So through an ilioinguinal approach, you can actually easily approach the SI joint as well as the anterior column of the fracture. You start in a floppy lateral position, you tilt your patient 45 degrees front and back, and then you can complete that with a posterior approach. You close the posterior column at the same time. You can actually twist the plate after you apply it, and you can have an anatomic reduction with a floppy lateral combined approach. There are some special situations where you need even more and more access. This is a hydatid disease of bone, which provoked this sort of non-classified fracture in a 36-year-old male. How do we do that? So the approach was needed not only to reduce and fix your fracture, but also to curette and get away the tumor tissue. And that's what we did. So what do you do with a case like this? Do you proceed with a replacement or a reduction and fixation? So we went in a floppy lateral position. We did a lateral window of an inguinal approach. You curette the mass that you have, and then from the posterior approach, you can completely reduce your fracture. You do a trochanteric flip. It gives you an access intra-articularly. And that's basically what we've done. So we ended up with an anterior and a posterior combined approach, simultaneous, floppy lateral position, and we obtained this satisfactory reduction, and that's basically his 4-year follow-up, and he's gone back to his work. So the combined approaches is particularly interesting for the acute cases that used to be used. With most of the cases that was advised for the extensile approaches in the back, in the past, nowadays we tend to rely on a combined approach, whether simultaneously or in floppy lateral position. What about the neglected acetabular cases? And this is part of our practice, unfortunately, in my part of the region. So you meet this 14-year-old young girl. She was hit by a car on the ring road, and she had an ipsilateral slipped lower femoral epiphysis. The initial treating surgeon obviously pinned her distal femur and presented to us more than 2 months after her trauma. So how do you plan that? What do you need to do? Remember, we have an associated pelvic and an acetabular fracture, so you need to approach the pelvic fracture. On the contralateral side over here, you can see that there is a contralateral superior pubicranial fracture as well as the associated both column fracture. So the plan is simple. You do an osteotomy for the pelvis, you reduce the contralateral fracture, then you do an extended iliofemoral approach. This is one of the rare cases where we did an extended iliofemoral approach to try to reduce the acetabular fracture. And that's her 3-year follow-up. What about combined approaches for neglected cases? Again, nowadays in my practice, I tend to prefer the combined approaches because they're less traumatic than the extensile approaches. The issue is how you plan your reduction and fixation. The floppy lateral in all neglected cases is the key. We cannot do this successively because you have to get an access to both columns at the same time. So this is a neglected transverse fracture. You can see the central dislocation of the femoral head. You have to plan it fairly well, so how are you going to do it? So in a floppy lateral position, you get an ilioinguinal approach, and then you flip the patient, you do the posterior approach, you get an access to the posterior column as well as the anterior column. And the patient has also a contralateral proximal femoral fracture, so the contralateral femoral fracture is pinned front and back. The problem with an extensile with a neglected case is that it's not enough to get an access to the column. You need to completely expose the fracture because you have to correct all healing tissues within the fracture. So this is what it looks like. This is what it was in the obturator oblique view. This is how it is at the end of the surgery. Also, we use the combined approaches for revision cases. Plenty of surgeons all over the place that are doing surgeries. When these surgeries are not adequate, you need to go back again, you need to remove the hardware, and you need to remove all the scar tissues to try to preserve the soft tissue as much as possible, remove the callus. The key and the difficulty in all these neglected cases is the reduction. And unless your surgical approach gives you a good access to every little inch of your fracture, you cannot remove the callus, you cannot mobilize your columns. And this is why either an extensile approach or a combined approach in a floppy lateral position gives you the access. The problem with a transverse fracture is that you have to reach the anterior as well as the posterior column at the same time. Sometimes we need to extend the ilioinguinal approach into a stopper type of approach to reach the column all the way to the greater sciatic notch. You need to be able to completely circle your columns from the back and the front. When you have an associated pelvic injury, the floppy lateral with combined approaches give you a better access than the extensile approaches because then you can actually reach the sacroiliac joint as well as the contralateral pubic ramus as well. So you can do an osteotomy for the pelvis as well as an osteotomy for the malunited acetabular fractures. And that's why the combined approaches have taken the lead to the extensile approaches in our practice. So the fixation has to be augmented. You have to put as many screws as possible because the amount of stress on the fixation is enormous. But at the end of the day, what we have learned is that although extensile approaches seem that they can give you a better anatomical reduction in an expert hand, a combined approaches in a floppy lateral position can give you a similar amount of reduction, and at the same time, it gives you a better soft tissue tolerance and probably better clinical results and gait abnormality. So these are very challenging scenarios that requires perfect planning. You must have a clear objective to what you need to achieve, but the best treatment for neglected cases is prevention.